Hey everyone, welcome to our webinar. Today's topic is, sorry, getting messages, uh, cortical and non-cortical myoclonus following cardiac arrest. Nabita Kaushal is our presenter today, but first I wanted to go through a couple of these slides, which is what's stumbling me up right here. So just some frequently asked questions and information that I typically get in the chat. I just wanted to cover first. So everyone that is in attendance today will get access to the recording of this webinar. You'll receive an email with a link to the recording about an hour after the webinar is over, and then you'll get another one identical email about 24 hours later. If you want CEUs, you need to attend this webinar using the link that was provided to you at registration. So it's actually documenting your name under who attended. You need to be in here for at least 45 minutes, and then you need to complete our post-webinar survey. So a link to that will also be in the same email as the recording video. If you want a CEU with ASET, then you need to provide your member number in that survey. If you are not a member of ASET or you don't need a CEU through them specifically, you just can leave that area blank and you'll still receive a certificate for attending. So moving on to the actual event here. So I'm Brad, I'm moderating today. Dr. Nabita Kaushal is our presenter. She's been with CortiCare for over 5 years now. She has 10 years of experience in the neurodiagnostic field, as well as 14 years of teaching experience in anatomy and physiology, as well as 10 years of research experience exploring the effect of sleep deprivation and hypoxia on the progression of neurodegenerative disorders. She's obtained her bachelor's, master's, and PhD, and currently holds credentials in REEGT, RNCST, and NACLTM. She's always a wealth of information. We're always excited to have her here for our webinars. So without further ado, here she is.
Thanks, Brad. Okay, we'll get started. This is another controversial topic among all the EEG techs out there. After cardiac arrest, the myoclonus that we are seeing, if it is cortical or not cortical. So I'm going to cover not just the myoclonus, but the events associated with cardiac arrest, what leads to the myoclonus, and how the EEG changes. Okay. I don't have anything to disclose, just that all the EEG samples that I have are taken from some of the research articles available on PubMed and some of the patients that I had monitored over a period of time. So during this webinar, we're going to talk about cardiac arrest and the hypothermia, the targeted temperature management, various EEG patterns associated with cardiac arrest, and types of post-hypoxic myoclonus and the EEG patterns. There are a couple of case studies. If the time permits, I will definitely go over those. We did have this webinar under a slightly different topic, I guess 2 or 3 years ago from CortiCare. Okay, so cardiac arrest or cardiopulmonary arrest is actually malfunctioning of the electrical conduction system of the heart. Okay, it's different from heart attack. So cardiac arrest, that's where the electrical conduction system goes haywire, which leads to an irregular cardiac rhythms that we usually call it arrhythmias. And this is going to lead to the cessation of circulation, not just to the brain, but to many other organs. But of course, brain is one of the most important organ here, and we're going to talk about it. Now, can this be reversed? Yes. If the help arrives on time, and the patient can be resuscitated and can bring back to normal cardiac rhythms. American Heart Association has given this algorithm to care for post-cardiac arrest patients. So our focus is, once the stabilization is done, where do we come in as EEG techs? So we know patient can be comatose after cardiac arrest, is intubated, or patient can be awake. They may be following commands, not following commands, depending on their clinical status, right? So in both scenarios, the EEG is done. When the patient is comatose, it's usually the long-term EEG that is done, and along with the hypothermia. Awake patients, they may have periodic EEGs, or they may be hooked up for long term. So that's where our role as EEG tech is important when the patient is presented to ICU or even in the ER post cardiac arrest. The hypothermia that is initiated after resuscitation in a clinical setting is very much different from the hypothermia. Just to differentiate these two, because I always used to think we are cooling the patient. Well, the patient gets hypothermia. How is it that different? So there is a different physiology playing here, okay? During hypothermia, as the temperature drops, from shivering to impaired consciousness, where there is absolutely no shivering. Shivering is actually trying to keep your body warm. The patient gets unconscious, and at a temperature of less than 24 degrees centigrade, there is no sign of life. And when we are doing target temperature management, this is actually a neuroprotective kind of an approach. This is to improve the neurological outcome by gradually lowering the body temperature between 32 to 36 degrees. I know 36 degrees is a normotensive, but different hospitals, different ICU teams, they have either adapted to a standard care or they have their own way of attaining this temperature, right? So some ICUs will work with 34, and some will even decrease the temperature to 32 degrees. And this temperature is to be maintained for 12 to 24 hours. And remember that this management, this TTM or hypothermia, is only on patients who are successfully resuscitated after cardiac arrest. So what's happening during that time? The body is cooled, like we talked about it, 32 to 36 degrees within 4 to 6 hours of return to spontaneous circulation. And then there is this is done for about 24 hours. In some places it goes up to 36 hours. And then gradually the patient is getting rewarmed. The rewarming is done very slowly. It's 0.15 to 0.25 degrees Celsius per hour. So it takes 4 to 6 hours for 1 degree increase in body temperature. And it will take almost, I would say, 20 to 24 hours for patient to come back to normotensive. If the patient develops fever when they are being warmed or once they are warmed, it can be detrimental. So that's why there is a very gradual increase. Very gradually patient is being warmed and the body temperature is controlled at least 48 hours after the rewarming. So what's the need for it, right? The patient is being resuscitated, patient is having the reperfusion and everything is going well, right? Of course, patient is intubated. So why do we need to induce hypothermia? Okay, this is basically, so when the cardiac arrest happens, we know that there is cessation of blood flow, there is anoxia, hypoxic injury, and all that is happening to the brain, right? So to improve the neurological outcome and to minimize any post-anoxic injury, the body is cooled. Cooling would lead to decrease in metabolic activity in the brain, okay? And it also decreases the oxygen demand. So if the metabolic demand decreases, of course, the oxygen demands will decrease. And that will help to reduce any damage caused by ischemia. And not only that, it is going to suppress the chemical reaction in the brain when the reperfusion happens. So it is going to suppress any of those chemical reactions. We do have side effects. Every treatment comes with a side effect. Side effects can be arrhythmias, infection, and even clots. There are some drugs used. Of course, the patient is in an induced coma with propofol, and of course, some meds are given to reduce shivering. We do not want the patient's muscles to be reacting to the temperature changes, whether we are cooling or the patient is getting rewarmed. And some neuromuscular blocking agents are also given during hypothermia, so that it's basically to avoid any of the side effects. Okay, so the heart and the brain association, of course, we know that both of them cannot live without each other, but hey, we are talking more of brain today. So what happened to the brain after cardiac arrest? The list here, you can see everything, or you can see one of this thing or multiple of these things, right? Patient can have seizures. There will be myoclonus. Patient can go into electrographic status epilepticus. There can be electrocerebral activity, not just during cooling, but after rewarming also. We can see burst suppression pattern. And then some patients will come back with background, with EEG background gradually. So that means from some suppression to burst suppression to delta theta to even to alpha, to the PDR. Keep in mind, patients after cardiac arrest, some of the patterns are malignant. The prognosis will be poor in those patients. Burst suppression is a mix. It can be a good or a bad prognosis. We'll discuss after a couple of slides. A non-reactive background, of course, is not a good sign. Alpha coma or spindle coma, generalized status epilepticus, and periodic discharges, whether lateralized or generalized. And the benign patterns are after cardiac arrest. It all depends for how long the patient was down and how much time had lapsed before the patient received help. We can see continuous or near continuous background of mixed frequencies, maybe some mild slowing here and there, the presence of reactivity. That is one of the most important things in patients to make sure if their prognosis is going to be better or not. And then we have absence of all the malignant features when the prognosis is going to be good. Okay, here is a list. So we'll go one by one, the EEG patterns after cardiac arrest. We know that each pattern is giving us a valuable prognostic information. Okay, so there are 4 typical patterns that we see: ECI, continuous background, burst suppression, and electrographic status. I know my video is coming on top of some of the text here. There are 2 different types of electrographic status epilepticus that we are going to talk, and they have different prognostic value. Okay, we are all familiar with the electrocerebral activity, inactivity. Keep in mind this value when the patient just had cardiac arrest and is on hypothermia protocol and you see a flatlined EEG, it does not have a prognostic significance for certain number of hours. You can start calling it a sign of poor prognosis if this pattern persists 24 hours after the cardiac arrest. So patient comes to ICU, is going to put on hypothermia protocol, you go and hook up and you see flatlined EEG, doesn't mean the patient is not going to come out of it. Another one is a continuous background. Here, a patient can have non-continuous or a continuous background or evolution of a non-continuous background to continuous rhythms. This pattern you see during hypothermia and also when the patient is coming back to the normal body temperature. Patient is waking up. You see this pattern. This is definitely a sign of good prognosis. Okay, burst suppression. So you have 2 different types of burst in this burst suppression images here. The burst suppression may or may not indicate poor prognosis. Based on the morphology of the burst, we can say if the patient is going to come out, will recover, or patient may have high mortality and may not recover after we see this pattern. The left side, if you see, you have asymmetric bursts. There are sharply contoured frequencies also you're seeing. There are some discharges. But on the right side, you have identical highly epileptic burst. This pattern has very poor prognosis. So that's why spontaneous and maintained burst suppression pattern after cardiac arrest may or may not indicate poor prognosis. So here are those two different types of burst suppressions. One burst suppression, so the electrographic status on one type of burst suppression here is okay, patient is burst suppression. Now we are seeing patient is EEG is changing and looks like the patient is going into electrographic status epilepticus. We are not talking myoclonus yet. We are talking just the EEG patterns after cardiac arrest. So from burst suppression, the status epilepticus develops early. Early means less than 24 hours, okay? And like I said, it develops from burst suppression. So the background was burst suppression, and patient is now going into electrographic status epilepticus. This kind of evolution of EEG has a poor outcome. Now, another electrographic status epilepticus kind, which develops from a continuous background. It develops a little later. It starts to appear when the patient is getting rewarmed or is fully warm. That means in the normal intensive temperature. This pattern, when it comes, this pattern reacts to anti-epileptic meds. So the outcome is better. So you have to be very clear. I know we are not responsible for the outcomes. We are not responsible for the treatments, but just so you know how the evolution of EEG happens post-cardiac arrest, how the changes are taking place in the patient's background says a lot about the prognosis. All right, so here is an example of electrographic status epilepticus from burst suppression. 12 hours after cardiac arrest, we are seeing these brief bursts lasting from half a second to 1.5 seconds. And the burst suppression pattern is having these repetitive epileptiform discharges. You can even call them birds. And then 16 hours after cardiac arrest, you see patient has continuous discharges greater than 1 hertz for over 30 minutes. So this pattern evolved from burst suppression, and now the patient is in an electrographic status. Let's look at the example from continuous background. So we see here delta theta rhythms. Patient starts to show repetitive epileptiform discharges. And these discharges are appearing 46 hours after cardiac arrest. So now we are past almost 2 days after cardiac arrest. These epileptiform discharges start to appear, and patient is going into electrographic status. This pattern works very well with anti-epileptic meds. That's why the outcome is better for this kind of EEG. Okay, now we switch gear to the main topic, the myoclonus, post-hypoxic myoclonus. Due to cardiac arrest, the brain gets less blood flow, less oxygen. So we have hypoxia, we have anoxia. It's basically the neurons do get injured. There may be necrosis of the neurons. The whole structure, the whole neuronal structure changes. The chemistry of the neurons change. And what leads to some hyperactivity and some hypoactivity of the brain cells. So there will be abrupt, irregular contractions of the muscles. So now we know the motor strip in the brain, the higher cortex is controlling the skeletal muscles, right? So because of irregular activity of those neurons, these movements will be abrupt. There will be irregular contractions. This can be focal or can be generalized. And almost 80% of the patients after cardiac arrest, they develop post-hypoxic myoclonus. There are 3 different types. One is acute, that you see immediately after cardiac arrest, within a couple of hours of cardiac arrest. It's also named as myoclonic status epilepticus. Then we have chronic post-hypoxic myoclonus, or the other name is Lance-Adams syndrome. This appears days and weeks after the cardiac arrest. And then there is subcortical or reticular or brainstem myoclonus. Usually with cardiac arrest, the term is reticular myoclonus, but since it is not coming from cortex, the term subcortical is also a usable term. And the reticular formation, since it lies in the brainstem, the term brainstem myoclonus is also used to describe that kind of myoclonus activity. Now let's talk in detail. Acute post-hypoxic myoclonus or myoclonic status epilepticus is not an accurate term because we are not talking myoclonic epilepsy here. But these are interchangeable terms, so just make sure that we are not talking myoclonic epilepsy or myoclonic status epilepticus due to myoclonic epilepsy. But we are still using those terms. So what's happening here? There is repeated myoclonic motor manifestations in a comatose patient. It starts within 12 to 48 hours. So different articles talk about different hours. Some are even talking after 8 hours. So I would say somewhere between 8 to 48 hours, this clinical sign will start to appear. The EEG will have generalized polyspikes. So the emphasis here is on polyspikes. And of course, we do see spikes, sharp waves, and these discharges are time-locked with the clinical signs. So it means the activity in the brain is appearing and is causing abrupt contraction of the muscles. When the SSEPs are done, they have giant potentials. This kind of myoclonus usually has very high mortality rate. So we may have burst suppression background with high amplitude polyspikes in lockstep with myoclonic jerks. So high voltage polyspikes, and it is clearly associated with myoclonic jerks. This is an example here. These are again heterogeneous bursts. That means the bursts on the right and left, they look very different, but the patient is having myoclonus activity with these discharges here. Okay, this one here again, these are again heterogeneous bursts, burst suppression pattern, and these discharges are time-locked with the myoclonic jerks. These are identical bursts, identical highly epileptiform high voltage bursts on a suppressed background. Here is evolution of EEG in a patient taken from this article here. On the day of cardiac arrest, the patient is having high amplitude polyspikes. There is decrease in the amplitude. If you see there, the term is used decrescendo in amplitude on a suppressed background. And these are time locked. Day one, the patient is still showing near continuous kind of these discharges, but the background is still suppressed. So here we see the duration of these discharges are increasing and the voltage is kind of gradually decreasing. On day 2, the bursts are softening. That means the high voltage that we are looking at is resolving. The background is still suppressed. The bursts are now sharply contoured mixed frequency activity. Okay, so what's happening on day 3? If you see, we are losing all the background frequencies here. On day 2, you would think, okay, it's getting better. But by the time day 3 came, now the suppression has increased and that background activity has become actually generalized periodic discharges. And this pattern coming from what it was on day 1, on the day of the cardiac arrest versus day 3, we are losing background frequencies, we are losing the amplitude, we lost the poly spikes. What we have is generalized periodic discharges. But going back to the very first time, what the pattern was, we had high amplitude identical bursts. And those bursts were poly spikes. So that too, when is added to the mix, the prognosis is poor. So you have high amplitude poly spikes. They are time locked. I said high amplitude, yes. And they are identical. So they are associated with high mortality in patients after cardiac arrest. Lance-Adams syndrome is different from the myoclonus we just discussed. Patient is still having myoclonus, okay? But that myoclonus activity, the contraction of the muscle, the abrupt jerking is not coming from cortex actually. So for someone to be diagnosed with Lance-Adams syndrome, all the sedation has to be worn off. And this myoclonic activity, it usually starts days and weeks after the cardiopulmonary resuscitation. Patients have regained consciousness, they are off sedation, they have woken up from their anoxic injury, but there is still myoclonus, there is still jerking of the muscles is happening. The background is continuous, and the discharges, we are still seeing discharges, and those are sharps and spikes. Those discharges are maximally focused at central or parasagittal region. Patient will have normal or near normal cognitive functions. So it means the prognosis is good. I have some examples here. Okay, before that, like I said, the EEG background, the EEG, you will look at narrow vertex spike wave discharges in lockstep with myoclonic jerks. I'm going to explain this again. We did have the myoclonus jerks are locked with the EEG pattern when we were talking acute myoclonus. In Lance-Adams, also it is time locked. Okay. So what's happening in this example here, during the hypothermia, the patient's EEG was attenuated, low voltage delta, and then once the patient have normal temperature, patient is warmed, is having normal temperature, patient started to show some forehead myoclonus around the eye. This is another example on day 4, patient is off sedation. So the previous example was debatable if it is Lance-Adams or it is acute myoclonus. Since the discharges are happening, just because they were focal, but also the discharges are not happening in the central and the parasagittal region, but they are frontally predominant. So this particular case was debatable if it is Lance-Adams or if it is acute myoclonus. In this example here, 4 days after the cardiac arrest, patient is off sedation, normal body temperature. If you look at this one, we have myoclonic jerks of the upper extremity and shoulder and face in a patient, in this patient here. Okay, so these discharges are slowly and gradually resolving. But if you look at the third picture here at the bottom, spiking diminishes. That's what the MD marks here. You can still see some discharges at the central central nodes. So this qualifies as Lance-Adams syndrome. Another example here is rest day 0. Low to moderate, I wouldn't call them low to moderate amplitude, narrow small polyspikes and attenuated background. And on day 4, the spike wave discharges with myoclonus continue. So there was no myoclonus happening on day 0, but the myoclonus disappear on day 4. For example here, 0 continuous background, mixed frequencies.
Hey, Navita,
and
your voice is breaking up over the past couple of slides. It's like your internet was going down or something.
From which slide? Do you want me to go back?
I'll go back to your previous slide.
Okay. Let me remove my headphones and see if that works. Does it work better?
Yeah, it sounds good now.
Okay, perfect. Okay, so I want me to go back to, okay. So we are talking Lance-Adams syndrome. So Lance-Adams syndrome is going to, the myoclonus is going to appear a couple of days after the cardiac arrest. Patient has already attained normal body temperature and the patient is off sedation. That is the key. Myoclonus appearing after the sedation is stopped is Lance-Adams syndrome. So it is not acute. It did not happen immediately after cardiac arrest. It did not happen when patient was on hypothermia protocol. So this one here, it happened when the patient was on at normal body temperature a day after the cardiac arrest. So we are still within the 48-hour range. So this particular case was debatable if it was acute myoclonus or if it was Lance-Adams. However, this particular EG taken 4 days after cardiac arrest, patient is at normal body temperature, absolutely no sedation. And if you look at this, the discharges are actually appearing on the parasagittals, which is a hallmark of Lance-Adams syndrome. And gradually the spiking diminishes, but you can still see some of it appearing at the midline. Another example here, very low voltage attenuated background with narrow and small polyspikes. Day 4, patient has spike wave discharges with associated myoclonus. This, since it happened post-arrest day 4, this is going to be Lance-Adams. This is chronic myoclonus. Another example here, continuous background. So here we do not have suppressed or a burst suppression pattern. Now, background is continuous. We are seeing these spikes which are associated with myoclonus. After 1 month, the EG was repeated, and this patient is still showing these spikes at the midline. The background, you can see there is a clear PDR is seen, so it means the patient has improved, but there are still some discharges along with the myoclonus. So this table shows the difference between the myoclonus status epilepticus, that is acute myoclonus, and Lance-Adams, which is a chronic myoclonus. Patient is comatose in acute, but is aware and conscious in chronic. 12 to 24 hours, and usually myoclonus stops after 24 hours in acute myoclonus. In Lance-Adams, it appears late and it becomes chronic. That means the patient recovered will be living with myoclonus jerks throughout their life. In status epilepticus, those are generalized, they are multifocal. Lance Adams, they are kind of localized, and the myoclonus activity it appears to be intentional. Okay, the biggest difference here, what the pathophysiology of it, right? So why we are still seeing myoclonic jerks in both kind of scenarios, but the pathophysiology is different. In status epilepticus, it's an ischemic brain injury and necrosis of the neurons. However, in Lance Adams, it's an hypoxic brain injury. And we know the prognosis is good when it is Lance Adams because patient has recovered, they are off sedation, they are cognitively fine. And prognosis is poor for myoclonus status. I do have a video to show you. I'm going to share my screen to show a video for Lance Adams syndrome. We have all seen patients in ICU hooked up to EEG having myoclonic status, right? So there was no reason for me to show that. So I'm going to show a video of a Lance Adams syndrome, a window here. Okay, you can see the screen, Brad, right?
Yep, looks good.
Okay, let's play that. So the patient is clearly following commands, seems to be cognitively inclined, but is having these jerking movements. Okay. All right, turn the screen share off and I have to go to the slides now. Okay, it went to the beginning. All right, okay. So in terms of one of the physician that I learned to read EEG, what he told me is it's a post-hypoxic neurologic phenomena. And it is not clearly epileptic. However, it is still treated with anti-epileptic drugs, which helps to control the myoclonus. So that's the biggest difference between myoclonus status epilepticus or acute myoclonus versus chronic myoclonus, which is Lance Adams syndrome. So myoclonus that is purely epileptic, and here what we are seeing, they are not epileptic. Those are the neurons behaving due to the hypoxic insult, due to cardiac arrest. Okay. The third type is subcortical. So we talked two different types of cortical myoclonus and now subcortical. Subcortical myoclonus is not just seen after cardiac arrest, but there are so many other conditions where patients in ICU are presented with subcortical myoclonus. And I'm sure we have hooked up these patients to make sure that they are not seizing. So this is some of the lists that the patient will have myoclonus, but they are subcortical. After cardiac arrest, damage to the brainstem, the reticular formation of the brain, which is controlling facial muscles, the sternocleidomastoid, trapezius, axial muscles, and the proximal limbs. So that area, when it gets damaged, the patient will show reticular myoclonus. So this myoclonus, this kind of motor activity is not associated with cortical EEG findings. Okay, like I said, it originates from brainstem. It is mostly bilateral. Very rarely it is unilateral. At that time when it is unilateral, you have to start thinking in terms of any local damage of the nerve or blood vessels. Patient will have generalized myoclonus, and these are the muscles involved. This is more of a startle reflex, okay? It's just like an exaggerated startle reflex, because that reflex originates from, startle reflex is physiologically comes from reticular formation from the brainstem. The bursts will be heterogeneous, and they are not correlated with myoclonus. There may or may not be epileptiform discharges, but again, those are not epileptic. They look like sharps and spikes because the way the electrical conduction of the neurons is happening. And when the SSEPs are done, they are normal. So here is an example. If you look at it in the background, you can see delta theta rhythms and myoclonus, which is high voltage muscle spikes. So what we're recording here is muscle potentials. The neuromuscular junction blockers, they play a big role in figuring out if the patient is having cortical or non-cortical myoclonus. So let's look at the picture here instead of reading this. So here is a patient where the continuous EEG is completely masked by myogenic effect. Patient is having myoclonus jerks, so it can be purely looking like patient is in myoclonic status. So after the neuromuscular junction blocker is given, you can see patient has near normal background, mild slowing, delta theta rhythms. There is no epileptiform discharges here. There is nothing epileptic in this. Okay, let's look at another example here. There is a rhythmic myogenic artifact. Okay, when the neuromuscular junction blocker was given, you can see patient having generalized periodic discharges. 2 to 3 hertz GPDs are seen. So it was hard to figure out what the EEG looked like. In the previous, you can still see some poly spikes in the background, but to clearly see what pattern is out there, the neuromuscular junction blocker blocks the contraction of the muscles and helps to bring out the EEG pattern. There is a case study from one of this article, which says post-hypoxic myoclonic status, the prognosis is not always hopeless. So we are talking about how this pattern is malignant and mortality rate is high. So some cases, patients do come out of it. So in this, on day 1, after hypoxia, background is slow, then we have very high amplitude myoclonic jerks, which are showing up in the EEG. Day 2, Vicronium was given to the patient, so this blocked the muscle contraction, and the patient is having 2 to 4 hertz of epileptiform discharges with bursts. So there is an electrographic seizure is happening. I wouldn't call it bursts. There is an electrographic seizure because patient is still having myoclonus. Okay, treated with Keppra, myoclonic jerks had resolved. The background is slower with some low voltage discharges. Day 8, the background is resuming its mixed frequencies. Slowing has decreased, but we are still seeing some discharges here. So this patient did improve after cardiac arrest, having myoclonic jerks, associated spike wave discharges, and by day 8, the patient definitely recovered. So just so you know, 7 days is a cutoff time actually in ICU. They think that if the patient is not responding, patient is not, how to put it, patient is not having any motor activity, purposeful movements, and the neuro exam is the worst. They think patient will not be regaining consciousness. Okay, so let's compare cortical and non-cortical myoclonus. So we know with cortical myoclonus, we have generalized spikes that are associated with and are time locked So there are two things. They are associated and are time-locked with the myoclonus. These discharges are associated with seizures. We saw different kind of EEG patterns with highly epileptiform bursts. So this cortical myoclonus is highly associated with seizures. SSEPs are giant. There is a craniocaudal progression of the activation of muscles. What does it mean? That means the myoclonus start from the head and then it spread to the body. It takes milliseconds for it to spread, but that's how cortical myoclonus presents. Non-cortical myoclonus, we do see generalized spikes. They are associated, but they are not time-locked to the myoclonus. Okay, they are not always epileptic. Many papers are out, they're saying that non-cortical myoclonus is purely non-epileptic, but we are seeing sharps and spikes, so one has to think. SSEPs are not giant, and here the muscles, the muscles that get activated, they are actually supplied by the brainstem. So it starts with the sternocleidomastoid, so the muscles here in the neck and the shoulders, and then travels to face, to the arm. So the way myoclonus happens is completely different than the cortical myoclonus. Okay, do we have time? Yes, we have time to go over two of the case studies. So here is a patient, 71-year-old, found pulseless at the bottom of pool, CPR for 10 minutes. Patient has history of cardiac arrest, status post-coronary bypass, diabetes, you name it, okay? So hypothermia was initiated. Patient developed status epilepticus chest myoclonus. Patient had no pupil or gag reflex on day 2. And day 3, the seizures stopped. That means the myoclonus stopped and the GPDs appeared. So this is in detail clinical signs of symptoms of the patient for 12 weeks. So week 1, there was absolutely no reflexes, okay, no response to noxious stim. So that is the cutoff time. 1 week is a cutoff time in ICU. The sedation was started to reduce on 2nd week. Patient is showing burst suppression. Reflexes are still absent. Patient is in coma. Is not waking up after the sedation is stopped. Family is refusing to withdraw care. Okay, so good thing they did not withdraw care. If you look at week 6 or 7, the patient is opening eyes, is responding to stimulus, okay? And then started to speak by week 9, speaking in short sentences. Week 12, patient is discharged to a rehabilitation facility. Okay, now day 79, patient is moving all extremities. So this is one of the good cases, a good outcome. This is what it looks like. The day of cardiac arrest when the patient was in status epilepticus, basically. This is week 1. Here are highly epileptiform bursts. There are myoclonuses going on. And here it is week 2, the sedation is reduced. Now you're seeing more and more discontinuity. Sharply contoured mixed frequencies and poorly formed discharges are still present. Patient is still in deep coma, no reflexes, and that's where family is refusing to withdraw care. Okay, this is day 72. So there are still left frontotemporal spikes. Background is continuous now with sporadic periodic discharges. Okay, this is the entire 3 years of this particular patient, how the EEG has changed. Depending on your screen size, you can see the colors. If you look at it, the generalized periodic discharges are consistently present for over 2 years. The blue bar here are the periodic discharges. The seizures, however, stopped by day 3. So patients stopped seizing, but continue to have epileptiform discharges for almost 2 years, okay? Now the burst suppression pattern, We have periodic discharges. We have discontinuity, suppression of the background. That is there almost for 8 weeks, the green bar here. Background slowing is present for almost 1 year. Okay. Posterior dominant rhythms start to appear, the orange bar here, start to appear somewhere week 9, week 10. It took patient for almost 1 year to have normal sleep transients. Doesn't mean patient wasn't sleeping. They were sleeping. Having sleep architecture is a sign of good prognosis. Even in ICU, whenever you hook up a patient who's comatose, you still see rudimentary spindles. That's a good sign. That's a good prognosis, actually. So took patient 1 year to show some sleep architecture. So this is one of the good stories. I have another case here, like you have guessed, it's not such a good story, right? 30-year-old female, cardiac arrest, on target temperature management, global myoclonus. Okay, patient's EEG has gone through so many changes in 1 day. So from this one with a burst suppression and highly epileptiform identical bursts to it's a seizure. It's patient is having electrographic seizure. Okay, there are more generalized discharges. The burst suppression with epileptic burst continues. And then we have burst suppression, epileptiform bursts 1 to 2 seconds apart. So how the EEG is changing just in 1 day, it's a day of cardiac arrest. Now here, the patient is having 2 to 3 hertz of GPDs. That means patient is basically in status. And day 2, some myoclonic jerks will start to appear, but the background is completely attenuated now. And it did get suppressed, but then day 5, the epileptiform discharges reappeared. Background is suppressed. Day 7. So basically this brain never recovered. Day 9. And at this time point, it says it's improving, but the patient clinically never improved. Stimulus-induced discharges kept on happening, and ultimately family decided to withdraw care for this patient. So that prognosis was not good. So patient never recovered from epileptiform discharges. The background never came back to any of those normotensive rhythms. Okay, I think that's all I have. These are the sources that I use for this presentation. And I'll take any questions you have. We still have 5 more minutes.
There are a couple in the Q&A
Okay.
section of the chat.
Chat. Okay. QA. Oh, okay, I see that. Okay. Is the neuromuscular junction blocker the same as paralytic? Yes. Yes, it's the same thing. I just didn't want to name names. Yes, those are neuromuscular junction blockers. They do the same thing. Okay, question from Susan. Do we use SSEPs to access for excitability and role of EMG for burst length? Yes, when they want to diagnose if the patient is having, especially during Lance Adams, they want to make sure that those discharges are not epileptic. And of course, when to differentiate non-cortical versus cortical myoclonus, the duration of the duration and the amplitude of the EMG potential makes a big difference. I haven't done it, SSEPs to distinguish between those two, so I cannot talk more in detail, but it is the duration and the amplitude of the EMG that clearly defines if the activity is coming from cortex or non-cortical, and at the same time, if they are distinguishing between Lance Adams and acute myoclonus. For these case studies, what were the MRI results? I do not have the answer to that question, so sorry about that. I think I did not focus on that part. But those were all patients from cardiac arrest, definitely have hypoxic and anoxic injury to their brain. Any other questions? All right. Thank you for coming. I hope the audio got fixed.
Looks like there's a few more questions coming in the chat.
Oh, okay. In chat or in QA? Chat?
QA.
Okay. Going to QA. All right. Okay. How do you know if it's okay to withdraw care? Oh my God, Amanda. We are not certified to say that. See, I always wonder whenever I'm contacting the doctor and saying, hi, patient is having highly epileptiform discharges and the background is suppressed. So, and then you would see patient is in a myoclonus, right? They are having these continuous jerks and it's basically status. And MD will tell, I don't want to get informed. So at that time, you would start thinking, oh my God, are they not worried about it or what it is? It's because they are aware the prognosis is going to be poor for these patients. Those patients are maxed out on all the sedation, all the anti-epileptic drugs that are out there. So based on that, like I said, 7 days, as per the research says, 7 days is a cutoff time. So that's when they decide based on patients' Glasgow Coma Scale, their neuro exam, of course, gag reflex and all that things, right? And what the EEG is showing. Then they will decide. Okay, Angie's telling us in tech, what is my role? Well, as a tech, I would say, we provide our technical description. We are not going into the details of whether the patient has poor prognosis. We are not reporting that. We are to report the description of the pattern that we are looking at, how it is evolving, how it is changing over a period of time. Some of you work 4 to 12 hours monitoring. You may see clear changes. 4 hours, you may not, but those who work longer shifts and you monitor the same patient day after day, you're going to see changes in EEG. And of course, your background knowledge will tell you if this is a good or the poor prognosis, right? But we're going to leave it to an epileptologist, to the neurocritical team to make the decision if the care is to be withdrawn or if the patient needs to be unhooked. Okay, Dilber is asking a question if myoclonic, not cortical, is Keppra. Yes, Keppra is given. Keppra is anti-epileptic drugs do control some of the myoclonic activity, but not always. Okay, Surat Kumar is asking, which specific EEG pattern in post-anoxic myoclonic status epilepticus predict poor neurological outcome with high specificity? So those will be your polyspikes, high amplitude, identical bursts or discharges. Any other questions? Okay, well, thank you so much.
Thank you all.